I know I took most of my time, but we have a few minutes.
We have a few minutes for some questions. If we can get people to support us with a mic, John, do these work?
So,
Otherwise, speak up.
yeah, take the far left one, Steve, all the way to the left. Yeah, that one. Okay, this side of the room, anybody? Don't be shy.
Got you all depressed?
Here we go. We have a winner.
Thanks for the great presentation, Mike. The one question I really had has to do with California, and we've always kind of prided ourselves on having a different approach to healthcare and a different model than a lot of the rest of the U.S. But I was wondering your thoughts on whether you think that sets us up to be more successful as providers in the state of California versus other parts of the country with ACA and navigating this challenging environment, or whether we have unique barriers or things that we need to think differently in order to be successful in this new world from a California perspective.
And it's an interesting question because I'll answer it first from a sharp perspective. We think that we are better prepared because we have stayed in the population health management game, and we believe population health management is where things need to go if we're going to address the cost curve and the quality curve, and we welcome that. We even welcome it in an ACO world if we can figure out how to get there. But our belief is we need to move away from fee-for-service. We can't afford fee-for-service, and that somehow we're going to get there, or the government will just continue to decrease the rates they pay us in a fee-for-service world, and that actually doesn't accomplish anything because we'll all figure out, okay, that means we've got to do more. Now, I say that, and I caveat it with, I don't know that all of California or that all of us as just one industry can make the rules. And I think that's one of the things that we're living through in our own strategies and tactics. Because as I said before, we used to have 330,000 managed care lives. It's now down to 290. San Diego used to have 65% of their Medicare population in Medicare Advantage. It's now down to 50. People like choice. I was just with PBGH last Friday with 3 other large healthcare providers, and PBGH represents the large employers across the state of California. They believe they're moving their organizations to a kind of what I said, the private exchange, which is they're going to move to models where health plans all sell a high deductible, very high deductible PPO product, and the consumer will become much more engaged in the price of care. Now, from our standpoint, in those kinds of products, that's not managing care across the continuum. That's managing care by the consumer based on price. And they'll go to, there's several software products out there today that you could punch in a procedure you might want, whether it's an urgent care visit or an MRI, and you'll find that the cheapest price is at X, and if you go there, because it's your financial incentive, that's not necessarily connected with your physician or connected with your continuum of care, so that's kind of disintegrated care. So I think we can wish all we want, but we're not going to be the ones who get to decide. Matter of fact, right now, the government, the payers are deciding. The employers, the PBGH model is those are large employers saying what do they think is going to save them the most money. I spoke to them a lot about continuum of care last Friday and how we can demonstrate on a capitated model the better outcomes and lower cost. I wouldn't say I got much traction. But that, my point is, we're going to need to adapt, and everybody's trying to protect their own market, which is what we all do. Every payer is trying to figure out, where is my future? What am I going to do if all of this is through the exchange? How do I differentiate? How do I manage care? The Affordable Care Act, in theory, all of these exchange products were going to be HMO products. There's only 2 HMO products, real true HMO prepaid managed care products in the 12. All the commercial carriers are paying discounted fee for service. Every one of them. So if you're in one of the Affordable Care Act bronze, silver, if you go into one of those are all fee-for-service plans. You may have a narrow network, but everything's paid fee-for-service, including your deductible, your co-insurance, your out-of-pocket. It's all fee-for-service, which was not what was intended by the Affordable Care Act. But it's what insurance companies liked. I mean, they developed a product that keeps them in the game.
Thanks, Steve. Hi.
Hi.
I'm sorry, this is kind of a personal question, but I am actually a SHARP patient, so thank you. And San Diego deals with so much military, and my husband's in the Navy. And I don't quite understand how TRICARE fits into a lot of this, because I've seen some organizations treat me like I'm Medicaid, where some treat me like I'm private. So it's kind of an interesting gray area that I am always curious about how it works. And so I was interested in how you guys loop it in, because some doctors are really excited when I come because they write me off, and some don't like me. So just to kind of go into that payers thing, where does TRICARE fit in the mold for everything for you?
Now, I'm not the TRICARE expert. I will tell you that TRICARE pays us less than Medicare. And TRICARE does, which means by the Medicare's own admission, means we're paying probably about 80% of cost. So we're losing money on all TRICARE we take care of. We do not contract with TRICARE except at one hospital. And we've chosen to do that because TRICARE pays so poorly. Our medical groups do not contract, so Sharp Steele does not contract with TRICARE, nor does Sharp Community Medical Group. At Coronado, where there's a concentration and there's not a hospital, we do take care of TRICARE patients there. But in the San Diego marketplace, the vast majority of the military's desire is to keep everything in Balboa, Camp Pendleton, or one of those facilities. We do end up with TRICARE patients. We certainly end up with TRICARE patients from trauma incidences. We'd end up with some of their OB. Obviously at Coronado, it's a relatively small hospital, but there is a TRICARE population there, so we do contract there. It is not a payer that most would say, yippee, which really ends up at the Medi-Cal, where I said before, less than half of the physicians in California will take a Medi-Cal patient today. And July 1, the state of California just cut all physician reimbursement 10%. So I don't think they're going to be signing up for more either. I don't know it all that much, so if you want and give me your card, I actually have somebody who knows TRICARE a lot better give you a call. I don't know it all that in that much detail. From our standpoint, it's left out of our conversation, and you're right, it's not in anything the community hospitals are talking about in San Diego, and that's mainly because they keep it in their own. I mean, they keep it in their own system. They have a VA hospital, Balboa Hospital, Camp Pendleton Hospital, and they don't want military in our hospitals.
Okay, we have one final question because we're almost out of time.
Richard Katz with HRMS. Thanks for the presentation and the big picture. So for all the health IT people that are in the room, and as a CEO with a comprehensive concept of what currently is and where we're going, what maybe 2 or 3 areas do you think health IT is going to be most impacted, and the kinds of resources that it should be preparing for in the next couple of years?
I'm sure Bill will correct my answer when he talks at 2 this afternoon. And actually, he'll correct my whole presentation when I talk at 2 the afternoon. You can get the real scoop from Bill. I think where we are really working hard, and our current IT department is working really hard, is how do we get our arms around data governance, and how do we define everything? And how do we make it a common definition so that when we put it into all of these systems like Crimson and Medventive and our data warehouse, that we're getting the same answer out for all of our locations. So, and then the second piece, other than the data governance that I would be, is related to all the tools that we're using related to our data warehouse, our Medventive, our Crimson, that will allow us to look at the population of patients and evaluate that population of patients and proactively manage those patients. And I could go on and on about the things that if we all looked at, people ask me, can we really bend the cost curve? Because of our data warehouse, when we got the 3 years of claims for the 32,000 Medicare patients, and looked at that data, and had we looked at that data back 3 years or now going forward, we had people who were going to the emergency room, not necessarily our emergency room, but emergency rooms in San Diego. I think we had one that went 50-some times in 1 year. We had probably 30 that went more than 30 times. If you were to look at the skilled nursing utilization, now remember, we discharge patients to skilled nursing facilities. It's in a Medicare fee-for-service world. Medicare pays 100 days, 90 days? I think it's 80 days. I think it's 80 days. What do you think the average length of stay of those fee-for-service patients were? Really high. What do you think the Medicare Advantage length of stay is? Same patients. Our Medicare Advantage population is almost a year older than our Pioneer ACO population. Our average length of stay in a SNF for a Medicare Advantage patient is 14. For a fee-for-service patient, in the 70s. Home health, they pay for X number of visits. They get a lot of visits. Do they need those visits? Are we managing across the continuum? If somebody needs 50 ER visits, and looking at the data, so going to where are we going to look at tools and what we're looking at, is how do we get information so that we can manage those patients, identify those patients, get them in chronic condition, chronic care teams, and allow them to have a better life. If they really need to be going 50 times, then we've got to figure out what their health issue is and help them manage that health care issue in a very different way. And that's where we're trying to go. There's predictive modeling built into those. But again, it's only a certain population of our patients. We're probably much more down this road than most other than Kaiser, but it's still only about 45% of our business is fully globally capitated. Probably another 20%, probably about another 10% is in these Pioneer ACOs and the other ACOs. The rest is still fee-for-service or discounted fee-for-service, which really they just keep lowering the rates because they don't know how to lower the cost other than that. Thank you very much for having me. I hope I helped you start your day.